want to overdose them. The dose is just a little bit lower. And if you have thyroid cancer, we will have a little bit higher dose just to suppress any thyroid cancers from coming back. Now, it doesn't matter what type of thyroid medicine you take, as long as you're consistent. That is the key. So a lot of patients will come and say, do I need to be on the brand? Do I need to be on the generic? It really doesn't matter as long as you're on the same type of medicine and consistently take it in the morning about an hour before you eat or drink. I just want to talk about, just briefly, about the signs and the symptoms of having too much thyroid hormone, too little thyroid hormone. Most of my patients are women in their 50s who are undergoing menopause, so a lot of these symptoms will kind of come with that, unfortunately. So it's sometimes hard to tell if this is from, just our bodily changes or from not having enough medicine or having too much medicine. But some of the symptoms of hypothyroidism is weight gain, which is a big one. You just feel tired, just pooped, you just can't go through the day without a nap. Heavy menstrual periods, joint pain, you're cold all the time. Like I said, some of these are very similar to menopausal symptoms. On the opposite side of the spectrum, there's hyperthyroid symptoms where you feel like you just can't sit there. You feel very anxious, you feel like your heart is palpitating out of your neck. There is some weight loss associated with that, brittle hair, and a host of other symptoms. So just in conclusion, so screening for thyroid disease, well, we do get a baseline ultrasound. Like I said, I've seen kiddos as young as 2 years old. We always know when it's a PTEN patient because most of my practice is not on pediatric patients. But we do screen at the time of diagnosis, which can be a little bit challenging. So I will have parents hold down their child, but get reassured that the ultrasound is really not an invasive test and it doesn't cause any pain to the patient, although anything coming to the doctor's office can be a little bit scary for our little ones. If you do have a normal thyroid ultrasound, I will follow them yearly with TSH levels, which is a blood marker for hypothyroidism or hyperthyroidism. Like I said, about 40% of the PTEN population will develop hypothyroidism at some point in their lifetime. And if you do have an abnormal thyroid ultrasound, that may lead to a biopsy and ultrasound and surgery if needed. So with that, I'd like to answer any questions.
So if you've had a fine needle aspiration of one of the bad nodules, whatever you called it, the
hypochoric nodule.
When should it be, and it comes back benign, if it changes in size, when should it be re-biopsied?
So once I recognize that a patient has a thyroid nodule, the first time I'll see them back at 6 months and then yearly after that. Every time they come back, we'll do an ultrasound and I compare the old measurements versus the new one. Technically, a growth is considered to be an increase in the size of the nodule in 2 millimeters in 2 different dimensions. So we measure it in 3 different dimensions. So that is technically the size. Now, millimeters are very small, so it's a little bit subjective depending on who does it, and you can't really compare a radiologist's ultrasound report to yours. So that's why I like to see my patients back and for me to do the ultrasound myself. If there is a growth, you need to be re-biopsied at that time of regrowth. Like I said, it's 2 millimeters of growth in 2 different dimensions. That's a very strict definition of growth.
And you do the ultrasounds, you repeat ultrasounds every 6 months?
So if the first time I see a patient, I'll see them back at 6 months, and if there's no growth, every year after that. If there is a growth, and we do the biopsy, and benign nodules can grow also, and if it is benign at that time, then I'll see you a year afterwards.
Thank you.
Is there a certain age in your Cowden's patients that you start seeing benign nodules?
So we have seen, like I said, we've seen thyroid cancer as young as 7. The youngest that I have seen a kiddo having thyroid nodules is about 5, because we do tend to see them as young as 2. Now, it is more difficult to see, and there's different types of nodules. So the 5-year-old kiddo that I've been following has very benign cysts, and they're all still considered nodules. The solid nodules I tend to see more in teenagers, but like I said, these benign nodules can progress to cancer. So we do screening ultrasounds at the time of diagnosis.
Are there a lot of kids who end up with biopsies that are benign?
Yes, absolutely. So, me and Dr. Ng just had a discussion on a teenager who does have a nodule, and it becomes very difficult. Even in adults, it's kind of scary to be in the office and have needles in their neck. So if a young patient needs a biopsy, we will do it in the operating room. If it does come back benign, then we'll watch them, just like we would do in the general population, and then we follow them. But the discussion that you need to have with, the patient and the child and the parent is that how comfortable are you following these kids, because they're not really used to getting ultrasounds every year, and it becomes a difficult test. We literally sometimes have to restrain them to do these tests. So there is a subset of patients that we will do prophylactic total thyroidectomies on, just because a follow-up becomes so difficult. But this is, an individual case. You really need to have that discussion with the patient.
No good answers yet?
No good answers yet, no.
What's the size that it needs to be before you biopsy it for a nodule?
So the hypocric nodules that I talked about, it has to be greater than 1 centimeter. All the other ones, 1.5, the isochoic nodules, the spongiform nodules are actually 2 centimeters. So the earliest we'll biopsy anything is about 1 centimeter, unless you have suspicious features that we talked about, like microcalcifications, hypervascularity, irregular borders. And some of the other things that we consider is a strong family history of thyroid cancer, previous radiation history in the head and neck as a child. So if I do hear those, those things, then I may consider biopsying something that is less than 1 centimeter, but definitely over 5 millimeters, because it's really difficult to biopsy something that small. Okay, thank you. Oh, did you have one more question? I'm sorry.
Sorry. You gotta raise your hand high and say, Kelly, get over here.
My question is actually a little bit unrelated to thyroid, but endocrinology in general. Have you seen any correlation with PTEN patients and type 1 diabetes?
No, I have not.
Talking with another mom, and Preston has all the antibodies for type 1, and so we're monitoring that. And she was saying her son has that. And so far I had heard it was unrelated, but I was wondering if what you had seen.
Unless Dr. Ng has some other info, no.
You're absolutely right. We don't know that yet, but we will keep an eye on that. In fact, as even patients age, it's the opposite. They get like 4 times older. And that's relatively recent to you.
Thank you, Dr. Shin.
Before we step out into our, before we step out into our breakout sessions, I would like for a patient testimony, Kelly Oliver Douglas. Kelly Oliver is a patient of the Lerner Research Institute at the Cleveland Clinic. She's a mother of 3, wife, volunteer, part-time road warrior, as an event manager for Intel Corporation. Kelly is also a 7-year cancer survivor, which, as most of you know, can be a job within itself. Kelly's journey began in 2011 and has led her through genetic counseling and testing, aggressive surgery and treatment, and into the world of remission. She likes to say she has parted with as many body parts as she can. She's fighting to keep the rest. So, Kelly believes in fighting cancer with humor and hope. Her cancer commandments to keep her family and herself laughing a little while setting a strong example. Kelly is living her own legacy of strength. Welcome, Kelly.
I'm taken aback because I didn't know I was up now. So hello, everybody. My name is Kelly Douglas. I am really honored to stand in front of you, all of you. You are my people, and I've told some of you that. I consider you my people. And I'm here to tell you a little bit about myself. As some of you know, I have Cowden syndrome. It's one of those crazy little mutations we're now a bit too familiar with. This makes me, as it makes many of you or your children, a mutant. Thank you for the laughter. It's supposed to be funny. My kids, embracing popular culture, tell me I am, here we go, Jana, I'm an X-man. So I advise you as my people to embrace that term as well. As I said, I'm really honored to be here today to stand in front of you and share. I don't typically get to connect with too many people who understand that PTEN is a gene and not a new brand of fitness clothes. So let's talk. One thing I wanted to say today is cancer sucks. Can you say it with me? Cancer sucks. There's really no other words that some of you have heard, and I've heard, that really cut to the quick of a person's heart than to hear, I'm sorry, it's cancer. You understand what I mean? You're faced with mortality. You're faced with uncertainty. Your world literally turns upside down. As she said, my journey began in 2011 with an amazing car crash that led to a breast cancer diagnosis, go figure, which eventually led to a PTEN mutation diagnosis, then more breast cancer, unexpected, surprise, eventually into kidney cancer. I used to tell Dr. Campbell it was good news, it was kidney cancer, not breast cancer in my kidneys, so let's look at the upside. I went through surgery about every 3 months for over 2 years with an amazing medical team, most of whom are here today. With them behind me, I'm standing with you today, and I'm happy about that. I'm scarred. I am missing more body parts than I'd like to be, but I'm here, and I made it through this part of the journey. I am in remission, and I hope to stay here versus cancer land for a very, very long time. Now, oh, thank you. I look into your faces and I want to tell you and remind you that this is our charge. Our charge is to be here, to get in front of this PTEN diagnosis no matter what, to empower ourselves with knowledge. And we're supposed to remember that knowledge is power. Oh, a little bit louder. Knowledge is power. That's a little bit louder. Our charge is to get aggressive on testing and treatment, and to take our medical care, with the help of these amazing professionals in this very room, into our own hands and drive it forward. We need to keep a sense of humor as mutants, and we need to keep living. My oldest daughter is a 19-year-old sophomore at Florida State University. She is living with a Cowden syndrome diagnosis, just at the time where she's embarking on life. And as she would tell you if she were here today, she's living her best life. Her name is Marin, and she reminds me nearly daily that we're all here to live. Having a rare disease, living with a rare disease, was not in my plan. I'm sure the word PTEN was never in your plan or the plans you have for your children either. But I believe, and I think we must believe, that we all have this funky little PTEN issue for a reason. We just have to find that reason and hold on to it. I believe we are all here because we are supposed to be an example for others embarking on a journey of uncertainty, possibly in cancer land. We are mutants, and a mutant is defined as a being who possesses a genetic trait that allows the mutant to naturally develop superhuman powers and abilities. I'm still looking for my superhuman powers, but maybe, just maybe, I'm closer to them than I know, and maybe you are too. I want to close with a quick quote from an X-Men movie. Told you, I'm an X-Man. You guys know who Wolverine, right? Is, right? Wolverine, the guy with the claws. So in this quote, Wolverine is talking. He's empathizing with a newly diagnosed mutant, trying to help him see a path forward. And he says, you know, there's not many people that will understand what you're going through. But I think this guy, Charles Xavier, and here's where I insert Dr. Ang, or Dr. Campbell, or Dr. Peterson, or Dr. Shin, he's one of them. He seems to genuinely want to help you. And that's a rare thing for people like us. So what do you say? We give these geeks one more shot. And how apropos is that? The people in this room understand what we, the mutants, are going through, and their knowledge becomes our power. So while we're here, while we go to these breakout sessions, let's connect. Let's empower ourselves with knowledge and community and keep living our best life. What do you say? Thank you very much.
Thank you. This is an amazing family of medicine in this room today, and as a board member of PTEN Foundation Board, I want to thank you, all you physicians, for your hard work and dedication, and thank you, the rest of you, for allowing me to be a part of your day. Okay, so these breakout sessions, you can see on your agenda how it's kind of broken out, and they're going to be in a few different locations. The west side room, or the water side room, the lake shore room, the bank side room. So I don't know if you want to get a pen. You can write it down. I can say it again. But there's also stands outside of each room, and it's just literally right across this hallway right here. What did you want? So if you want to go to more than one breakout session, you can, and the time allotment is, I know what you're saying, it looks kind of confusing on there.
So are they all going on each time? Is that?
The way I understand it is it's going to continue to go on. So you see what I mean? So it's not like you're going to go from one room to another to another. It's going to be, it's set up to where you can go to the ones that you want to go to. And the doctors are looking at me, confused. Okay. It's right. Right.
Each session in each room will reoccur 5 times. So if you in particular want to go to one topic, you can stay the whole time. Or if you want to go 20 minutes to this one, then you go 20 minutes to that one and 20 minutes to the next one. So there's 5 different sessions that are going to run in each room 5 consecutive times. Make sense? Yes. Awesome. Good deal.
Thanks, Kristen. I confuse people sometimes. So I hope this makes sense to you. I want to say that coping with autism, diagnosed now what, will be in the waterside room. Thinking and feeling with Dr. Robin Bush will be in the lakeshore room. Speed session number 3 will be in the bank side room. And again, above the doors are all labeled. Let's see, speed session 4 is in the fountain view room. And speed session number 5 is in the island view room. Anybody have any questions? Are we good?
I'm gonna go ambush that.
Bankside will all the way through. Bankside is
Yeah.